And that brings us back to our two lawsuits. What happened here? Why did these two cases end up being so dramatically different in their outcomes? The suicidal patient escapes an ambulance and dies. The EMT is found liable and grossly negligent, as opposed to the drunk patient leaving the ER getting struck by a vehicle. Physicians not liable and had no grounds to hold the patient against his will. Why the difference? Well, first let's ask this question with Brett. Why did that jury find the provider grossly negligent? Was it because the EMT allowed Brett to escape and ultimately this led to Brett's death? Did they expect that the EMT had a responsibility to tackle the patient in the back of the ambulance and pin him to the floor until help arrived? Or was it because he applied and monitored the restraints improperly? The jury felt that these tragic events were set in motion when the EMT made two significant and preventable errors that another EMT acting in accordance with the standard of care would not have made. First, allegedly, he applied the soft restraints incorrectly. Now, what that means exactly, we don't know. But the second issue was that he moved from the bench seat, a position that afforded him an unobstructed view of Brett's restrained limbs. He moved from there to the captain's chair, which, with Brett in the semi-Fowler's position, impeded his view of the restraints. The jury believed that if not for those actions, Brett's death could have been prevented. So, Brett was suicidal. Kowalski was not an overt, imminent threat. Now, I want to stop there and focus on this for just a second because I think this is really worth understanding. You could look at this and say, well, wait a minute, the patient's drunk. That's a threat. But is it an imminent threat? In other words, could someone look at that situation and say, more likely than not, if this patient leaves this hospital on his own, he almost certainly will be injured or killed? Could we have said that? Not really. It's not really imminent. He might trip and fall. He might walk out in front of a semi. He might fall off a bridge. But is that really the most likely thing? That's really hard to say. How many of you out there have ever been at home intoxicated and hugging a toilet after having one too many adult beverages? If EMS all of a sudden showed up knocking on the door and said, hey, we're taking you to the hospital and you don't get a vote in this matter, how would you react to that? You'd probably say a few choice words. My point is, there's no imminent threat that something bad is going to happen just because someone is intoxicated. But in Brett's case, he was known and admittedly suicidal and had also evidence of delusions and hallucinations. Whereas Kowalski, however the physician made the determination, we don't really know, but Kowalski remained in possession of his mental faculties. In Brett's case, then, involuntary care was justified, whereas it was not in the Kowalski case. Capacity is the only thing that really matters here. Just because a person is a psych patient, that does not automatically mean that they lack capacity. That label means very little. But if they are in a state where they are uncontrolled, they're off their medications, they're out of touch with reality, they're hallucinating, their behavior is unpredictable, that's when we start to question their capacity. And by the way, I alluded to this earlier. What about an accidental heroin overdose? A patient who is given Narcan and now is lucid on the scene. They weren't trying to kill themselves. There's no evidence that they were suicidal. They just accidentally overdosed on heroin. Can we look at this patient and say they have mental capacity to refuse care and transport? Yes. In that moment, they have capacity. But we have to clearly communicate all of these risks and make sure that they comprehend and appreciate those risks of what might happen if they refuse care and transport, and then document the heck out of it. And I think what really summarizes all of this really well is a quote from a nurse who is also an attorney. And this is what she said. Providers must respect the legal rights of all patients, and that includes those who present with mental health or intoxication issues. We can't take a paternalistic approach and hold someone against their will simply because that's what we think is best for them. We assess them to determine if there is immediate risk of injury to themselves or others, and the decision to involuntarily detain them is based upon that determination alone. If the determination is that the patient does not pose an immediate risk, we then explain the risks, the benefits, and alternatives of leaving against our advice and document that conversation. But patients have the right to make their own decisions about staying or leaving. The laws regarding patient rights reflect a culture that values autonomy and respect for a patient's ability to make decisions regarding their own health care. Does the patient have capacity? So now that I've left you absolutely terrified of the prospect of ever transporting an involuntary patient again, I want to take things from the other direction now and talk about things to look for that justify involuntary transport and the use of restraint. But first, all right, this is the interactive portion of today's session. I am going to attempt to read your mind. All right, stay with me here. This is going to require a little bit of math on your part, so I promise it's not going to get any more difficult than that today. But here's what I want you to do. First, think of a number between 1 and 10. Okay, do you have your number? Next, multiply that number by 2. Then, add 8. Next, divide that number by 2. And then, lastly, subtract your original number, the one you picked between 1 and 10. Have you got it? All right. I'm putting a chart here on the screen, and what I want you to do is find the letter that corresponds to your final number. Next, think of a country that begins with that letter. Take the second letter of that country's name and think of an animal that starts with that letter. And then lastly, think of the color of that animal. All right, have you got it? Okay, you are thinking of a gray elephant in Denmark.
Explosion.
Now, obviously, this is not real magic. There's no such thing. This is simply mathematics and probabilities here. The thing of it is, there's only 4 countries that begin with the letter D. There's Denmark, Djibouti, Dominica, and the Dominican Republic. If you came up with a name other than that of a country that started with a D, I'm sad to inform you that that wasn't actually a country that you thought of. It's probably a city or something. Delaware is not a country. Regardless, in our hemisphere, most people, if you ask them to think of a country that begins with the letter D, they're going to say Denmark. It's just a probability. The point I'm trying to make is that we may not be able to predict the future, whether someone's going to become violent en route to the hospital, but there are certain things we can do to look for probabilities that the risk is greater than normal. The issue here is knowing your patient. This is an actual report of an assault on EMS providers. I've read close to 400 reports of assaults on EMS, and I was looking to see if there were any common denominators, red flags, or risk factors that you could point to and say, if you see these things in your patient, you need to give serious consideration to physical restraint or chemical restraint. Are there any common themes? And I found that there are several. So before I list those out, I want to kind of set the tone here. In this case, it was a routine transfer, 3-hour-long trip. When EMS arrives to take the patient, they find the nurse says this patient had trouble with women and sexually assaulted and killed a cat. Despite that information, no restraints were applied. And en route to the hospital, the patient became what the attending paramedic deemed psychotic, at which time the patient tried to unbuckle his seat belts and then proceeded to punch the paramedic in the face and then bite down on his finger.
Oh, that's going to leave a mark.
The paramedic, after multiple attempts to dislodge his finger, he felt he had no choice but to punch the patient in the face to free his hand.
Boy, that escalated quickly. I mean, that really got out of hand fast.
It jumped up a notch.
It did, didn't it?
Law enforcement responded. The patient was given Versed and put in 4-point soft restraints and given a spit hood, so everything but the kitchen sink. And this was the very last line of this report. Verbatim, this is what it read. The remainder of transport was uneventful.
It's a Festivus miracle.
I can't say that the list of risk factors that I found say if you see these things, the patient is definitely going to try to kill you. What this list does is simply says that of all the patients who might try to kill you, one or more of these things is probably going on. It's a correlation, not necessarily causation, but we need to have heightened levels of security anytime we see one or more of these risk factors. The biggest one by far is intoxication, drunk, drugged, or both. Another one is psychosis, and what we mean by psychosis is out of touch with reality, meaning delusions, hallucinations. So they are seeing, believing, hearing things that are not really true. Or their behavior is bizarre. I set that apart from psychosis because it's not that they're hallucinating or delusional, but their behavior is just way out in left field. Like I read a report of a patient who was inside a Denny's restaurant and walked up to multiple windows and put his face through those windows. That's a little bizarre, kind of like dancing naked on top of a tractor bizarre. And then other things, the patient is altered. They're postictal, hypoglycemic, traumatic brain injury, etc. There is a heightened risk there. If the patient is suicidal, if they have a psych history, and not just that they have a psych label, but that there are other things going on. Maybe it's a schizophrenic whose medications, they've not taken them, they're not keeping up with it, and now they are uncontrolled and they are psychotic. Those are the psych patients of concern, not just someone who has a label. Involuntary patients in general, those who are adamantly or desperately refusing care and treatment, those patients are a greater risk. If they have displayed threatening body language or tone of voice, etc., those things are red flags. And what do all of these traits have in common? The behavior is unpredictable or irrational. Unpredictability is probably the single biggest red flag that violence may occur in the back of the ambulance. And there's another grouping though. Known criminal, or they have a history of becoming violent in similar circumstances. Like if you respond to a home where a man has taken some sort of drug and the wife greets you and says, hey, listen, the last time he took this drug, normally he's a perfectly nice guy, but the last time he took this drug, he beat the snot out of our neighbor and tried to kill someone. This is a good critical thinking question here. Even though this patient today has taken that same drug, but they have not yet displayed violence, can you use the past event as justification to restrain them today?
No. Well, yes.
Yes, you absolutely can. Just be clear in documenting who said what and back yourself up there. Right along with that, aggression that was displayed prior to your arrival. Maybe they fought with police. Maybe it's an assault call. When you arrive, you find the patient in custody or handcuffed. Now, what about this one? It's a routine transfer, we'll say. And you arrive and you find out that this psych patient had to be restrained, sedated, or secluded in the ER. But the nurse who greets you says, oh, yeah, he was really unruly, gave us a lot of problems, was trying to bite people, and we had to restrain him and give him Haldol, a couple of nights ago. But, he's been perfectly fine for me since I came on shift 5 minutes ago, so you shouldn't have to put him in restraints.
You serious?
You hear a nurse say something like that, you better put that patient in restraints, because that's relevant, immediate history. Assaults or attempts to assault the crew prior to transport. Yeah, if the patient tries to kick your ass before you even leave, there's a pretty good chance they might try to beat you up in the back of the ambulance. And what do all of these traits have in common? Relevant history, behavioral patterns. Because the best predictor of future behavior is relevant past behavior. Again, be very clear in documenting who said what. That's going to be critically important in these cases. But what about those gray areas? What if you have someone that doesn't quite fall into any of these categories? You see something, you just get that gut feeling that says, man, I can't put my finger on it, but there is something here that's telling me I've got red lights and alarms going off saying this guy is going to be a problem, but I don't have anything that I feel like I can point to and say this justifies putting the patient in restraints. What can you do? Is there any middle ground? And yeah, there actually is something that you can do. Here we have seatbelt locks. This is a great device, and if you don't already use them, I encourage you to start using them. However, I do want to emphasize a couple of things about them. First, this is minimum level security. If you have all the justification you need to put someone in 4-point restraints, put them in 4-point restraints. The seatbelt lock alone can be beaten, but it does slow someone down. So if someone starts to become unruly in the back of the ambulance, this at least will slow them down enough to give you time to react, whether that is fleeing to safety, or if you've got enough hands, putting the patient in 4-point restraints at that stage. But also be very careful about taking an ink pen or something else to release this patient from the seatbelt lock. If their hands are free, they can very easily grab that ink pen and jab it right into your eyeball if they so choose. So my point here is that your safety comes first. And this is the last point in our conversation today, and I want to emphasize and underscore this in every way humanly possible. The moment the scene becomes unsafe, your duty to that patient ends. Period. So if you have a 280-pound guy that's 9 foot tall, bulletproof, mad as a hornet, and ready to kick somebody's ass, and he is telling you that he is going to beat the snot out of you if you don't pull over the ambulance and let him go, if he can reasonably carry out that threat, you better let him go. Imagine that. Something bad happens and you get sued. A judge and jury is going to look at that person and go, yeah, I'm pretty sure this dude can make good on that threat. So yeah, case dismissed. Now replace that big dude with a 90-pound, 98-year-old female who's bed confined and a dementia patient, and she says, you better let me out of this ambulance or I'm going to kill you. If you were to let her go and something bad happened, imagine that. Then the judge and jury are going to look at her and go,
you serious?
And you're going to be hung out to dry on that case. It has to pass the reasonability test. Not every situation is textbook. Nothing works 100% of the time. We could what if this kind of thing to death. What if this happens? What if the patient does this? What if that? All I can do is give you some advice, some general advice, some tips, and help you build a foundation, help you practice. But when it comes time to play the game, I and the other training officers, the closest we can get is the sidelines. It's up to you to play the game.
You